This is Deborah Zaritsky for Bio 520, Grand Canyon University. Today is May the 13th, 2020, for Dr. Harakos, talking today about the heart. Contrary to popular belief, the heart is in the middle of our chest, sitting right beneath our sternum. We have the apex going towards the left side of our body there, and we also have the aorta pumping a lot of blood to our tissues, a lot of oxygenated blood. So how is it that our heart is able to do this in such a systematic way? And we hear that lub-dub, lub-dub. Well, we know that the heart has 4 chambers. We know that the top chambers are called the atria. The bottom chambers are called the ventricles. We know that the red is going to symbolize oxygenated blood. The blue is going to symbolize the deoxygenated blood. So inside of our right atria there, we have the sinoatrial node. We have the atrial ventricular node that sits right there in between the two. We have a structure here called the bundle of His that will run through the septum. At the apex, we're going to find our Purkinje fibers. And we know that about 99% of the cells within the conductivity system of the heart are going to be called contractile cells, which we can see in this diagram here. The other percentage are going to be autorhythmic cells. And these autorhythmic cells are going to be generating some action potentials through something called a pacemaker action potential. So we know that cardiac cells do not contract, but instead they're specialized for initiating and conducting the action potentials responsible for contraction of the working cells. According to Sherwood, an autorhythmic cell membrane's slow drift to threshold is called a pacemaker potential. These lines here are going to represent certain ions that are going to be exchanged through the channels to generate particular waves referenced as PQRST, and we will talk about that momentarily. So the membrane potential that we're seeing here for our autorhythmic cells are going to be in a system of 4 phases. So phase 1, we're going to have an early rapid repolarization result from rapid inactivation of sodium current carried by potassium ions. So we're going to start off here at about a negative 60 millivolts. This was going kind of backwards here, so we had a repolarization. We're going to go ahead and we're going to lift that threshold by a release of sodium ions. As we get to our optimal threshold, we have exchanged for our sodium and potassium. We're going to also get a slow leakage from an L-type calcium channel. So we have these channels called funny channels, and it allows sodium in and the closure of potassium channels, which reduce the outward potassium current, and the opening of these T-type calcium channels. And when the threshold is optimized, the rising phase of the action potential is a result of the opening of the L-type calcium channels. Again, L-type meaning long-lasting. So then we have the falling of the potential caused by the opening of the potassium channels. The potassium permeability is not constant, and they close very slowly. Then we're going to have something called a clock mechanism that allows the system to be continued. So according to Sherwood, the heart rate abruptly becomes greatly accelerated and continues this rapid rate for a variable period until the ectopic focus returns to normal. So what is an ectopic focus? We will discuss that in just a moment here as we talk about what could possibly happen if this system, these action potentials, gets disturbed. So we have some overly irritable areas that might be associated with heart disease, but more frequently they are a response to anxiety or lack of sleep, excess caffeine, nicotine, or alcohol consumption. So even though we're going to have this disturbance, it might be short-lived, but might cause some heart disease down the line. So this ectopic focus, as we talked earlier about the sinoatrial node, that's where most of our impulses are going to begin. So we have a rate of about 70 to 80 millivolts. Within our atrial ventricular node, it's going to be between 40 to 60 millivolts. And then when we have that bundle of His, which is going to be right over here, and then our Purkinje fibers, that's going to be about 20 millivolts. So these are a lot lower than our sinoatrial. And we know that in our sinoatrial node, it kind of works, the impulses work their way on downward. And that's what creates that steady rhythm there of 70 beats per minute. But when the SA node kind of spits out some difficult impulses there, and it doesn't quite get to the atrioventricular node, then we're going to have some atrial fibrillation. So that's where this is coming from. I'm sorry, I'll go back to the ectopic focus here in just one moment. Sorry, I just kind of skipped that. I went down this way. So we've got going back to the ectopic focus. So that's gonna perhaps lead to another one of these nodes that might take on more of a role in the lead. And what would happen there, or what might happen in the other ectopic focus, is we have a contraction of the Purkinje fiber, and that would lead to perhaps a quiver there. You know, we're talking about the atrial fibrillation as well. Not only would it cause a kind of a quivering, but we have tachycardia, and that's when our impulses are going to become a little bit more rapid. We're going to see a higher frequency if we were to do what's called an EKG, which I will talk about momentarily. So bradycardia, that's going to be where our heart has less than 60 beats per minute. Tachycardia, again, might be caused by medication, anxiety, external stimuli. So here again, this is our lead here. If our sinoatrial node were to collapse, then we're going to have a much lower voltage here. Because if our AV node takes over, then we're only going to be as good as that amount of voltage that it's giving out, which is 40 to 60. And then if that were to go out and we're only depending on, let's say, our Purkinje fibers, that's only at 30 millivolts. If we get down to 30 millivolts, a patient might become comatose. Our heart would no longer have that conductivity. So a greater percentage of our cells, as I said, are contractile cells. The contractile cells are going to be within our ventricular areas. They're going to be kind of in the back there. So again, the SA node gives off our impulses straight to the AV node, goes to the bundle of His, down to our Purkinje. Funny, I always thought the septum was just cartilage, and now I understand that that's where our conductivity is. So this is where we're going to have a release of our sodium channels. Sodium channels are going to open. They're going to give us a big increase here. So as our sodium starts to deplete, our potassium starts to deplete. Our calcium channels become open. We have an increase in potassium, decrease in calcium, back to our resting potential. And then we're going to go ahead and get back to our plateau phase. With the plateau phase, we're going to have a slow L type of the calcium and a low potassium permeability, and that's going to give us a refraction period of about 250 milliseconds. And as I am saying this, I believe that this is applicable towards our pacemaker action potential. So that's where we're going to see a plateau phase here, and that's going to allow the ventricles to fill up. And so we need a little pause there. So even though we need a continuous message impulse, we need a little break there for our blood to exit and fill. So what are the difference between the two? We have the autorhythmic cell. We start off with our sodium, potassium, calcium, going back down. And here our sodium in an increased rate, and we have a very slow drift, slow release of our potassium. So that resting potential close is to the potassium equilibrium potential of a negative 90 millivolts. So how do we know if we have AFib for sure, or how do we know we have myocardial infarction, or a bit of atrophy in our myocardium? Well, we would take an EKG or an electrocardiogram. So what we do is we would take electrodes and put them in various areas of the body, and we can kind of look at it like an upside down triangle. And these are called leads. And they're going to show us our right ventricle, left ventricle, and then our flow down here. So once we look at our EKG, it's going to show us that our P waves are going to be for atrial depolarization. Our QRS waves are going to be for depolarization or atria repolarizing. Our T waves are going to show us our ventricular repolarization. We also have a PR wave that's going to show us AV nodal delay. That's our atrioventricular node delay, and that delay could be up to 100 milliseconds, and that's the emptying of the contents into the ventricles there. Q is going to be kind of hard to see. Q kind of dips down a little bit. Let's see if we can find a Q. So we got a little Q, but I'm not. So in a normal wave here, the Q is going to be right after the P. And then we've got the ST wave. That's our ventricles contracting and emptying. We have our TP. Ventricles are relaxing and filling. And I just found this very interesting. So comparing our normal EKG and our sinus tachycardia. here are my references, and thank you so much.